So next speaker is Dr. Thomas Cherian, sir. He is a head of Department of Vitreoretinal Service at Little Floy, Angamali. He is a veteran surgeon with years of experience, and as we all know, retina is a specialty with a lot of complications. So I think he's the best person to tell about how to tackle patients during complications or with poor visual gain, and how to ease your tension from his years of experience. Thank you, sir. Over to you.
Thank you, Rakhi, and good morning. When you have a complication on the table, Ambika would go for a deep breath and pranayama and yoga. Rakhi will be dealing with pure science, how she will manage the complications, arrange the vitrectomy, get everything done. All this, yes, but in the back of my mind, I would be rehearsing after the surgery, 15 minutes down the line, what am I going to talk to the patient and the bystander. So that is what we face in our day-to-day practice. Not for a vitreoretinal surgeon alone, it's there for everyone. Everyone has his or her share of complications because we are all human beings working on the body of human beings. So it can't be like machine or AI. There's bound to be some complication in our day-to-day practice. So what are all these complications? First and foremost is error from carelessness, which we have. That is a complication. We'll go into all these one by one. Second, we have a wrong diagnosis causing complications. Third, we have difficult surgical procedures where complications are expected and sometimes you'll end up with complications. Sometimes you have unexpected complications. In certain cases, your surgery has gone well, everything was fine, but first post-operative day or second post-operative day or after 1 week, you have some unexpected post-operative complication. Sometimes it's not a complication as such, but the patient's expectations go beyond reality. They expect that everything will be fine and they are not getting that desired outcome. We have to manage that also. At times we have to manage complications of a colleague or someone who has referred a patient to you with complication. And in certain conditions, patient has come on his or her own with complication by a surgeon elsewhere, either from your own specialty or from a different specialty, subspecialty. Patient did not get the desired outcome and quietly he slips away from that place and reaches you. So all these are situations which we face in our day-to-day practice. How do we manage error from carelessness? That is something which we have to be on our toes day in and day out. If you are a practicing ophthalmologist, if you are a surgeon who is operating on patients, we have zero tolerance to error. We cannot afford to operate the wrong patient. Sometimes patients have similar names. There could be 2 Abdul Qaders in your list or there could be 2 K.M. Matthews in your list. It's not an excuse. So before you start the list, always study the list. Who all are there? What all procedures are there? Look at the case sheet, study the list. Don't just operate on the patient whom the sister puts for you on the table. Study the list, study the case sheet, study what you have written, not your fellow has copied. There could be a change there also. So what you have written, sometimes you also face these mistakes, write down mistakes, but then someone points it out to you and with a word of thanks you proceed. And always have checks at the multiple levels. The sister in the ward, sister in the operating room, sister, the scrub nurse, the circulating nurse, your fellow, yourself, everyone have multiple checks, and these checks should not be like, yes, Prime Minister. Everyone should do an independent check. Now you could have the wrong eye. Sometimes you check all these, put the patient on the table, and I have faced a situation when I have rechecked the patient's eye, it's the right eye with the case sheet, went on, changed my gloves and came back and had the left eye draped and I went into the left eye. That I have faced on the table. Now the wrong procedure, there could be a wrong intraocular lens, the power calculator could be wrong, the type of lens could be wrong. Cataract surgery in patient who is posted for an entropion correction, the patient is on the table draped and you don't know what it is. And as usual you go in and do your cataract. It could be a wrong vitreoretinal procedure. Someone who has come for an anterior vitrectomy might have an ILM peel. So unless you check multiple times, be very thorough with the case sheet, be very thorough with the patient and go in, you can't avoid all this. And patient for a combined cataract and glaucoma procedure, had only a cataract surgery and went out of the operating room. This could also happen. So all these, we have zero tolerance, but still in spite of this, sometimes these errors happen. And when this happens, you should not leave it to the operating room sister or to the ward sister or your fellow to talk to the patient. You should take it up by yourself. The surgeon himself or herself has to talk to the patient, because the patient has confidence only in you. Patient knows only you, no one else in the hospital. If necessary, you can take the help of a colleague or a senior colleague or an administrator, whoever, to talk to the patient, but you should be there. If it has not done a harm to the patient, explain it. Recently I had a patient, a baby, who had a nasolacrimal duct obstruction. Probing was posted for one eye, but someone did a probing in the other eye, and there's no harm to the patient. So we talked to the patient that nothing has happened. Anyway, we'll do the next eye also, so don't worry about all this, and kept the patient comfortable. You can subtly discount the bill, but don't waive it off. The patient should not be your enemy at the time when he or she gets the bill. You should give a bill, always give a bill, but you can subtly discount it a little bit. Refer to a colleague or a higher center wherever necessary, and you please arrange the referral yourself. Don't just ask the patient to go to Madurai and do it. If you are sending to Madurai, then try to get a contact surgeon there. Find out which day the patient should be sent, and the patient should be comfortable when you are referring to another place. Now, wrong diagnosis causing complications. You can miss a vitreoretinal or a disc pathology, get a cataract done. A VR surgeon, when he is operating, sometimes might find an intraocular foreign body which has not been detected earlier. Can I take a few more minutes? Intraocular foreign body or an IOL which has been displaced in the vitreous cavity. A cataract surgeon might be missing a lens subluxation. When this happens, don't overreact. Gently tell the patient just what is essential. If the patient had an intraocular lens inside the eye, don't just make a hue and cry over that. Again, I'll tell a patient, patient came with a pseudophakic bullous keratopathy with an AC IOL and one more IOL inside. So I removed that AC IOL, then I got one more IOL removed, did an anterior vitrectomy because I didn't have much fundus view, and sent the patient away. And 4-5 months later, one of my friends from another VR surgeon from another hospital is calling me telling, Thomas, you removed an IOL from a patient. My discharge summary only had an IOL removal with anterior vitrectomy. Thomas, you removed an IOL from one patient, and now I find another IOL in the eye. I said, okay, that is the third IOL. I removed 2. But then please don't overreact to the patient and tell him that you had 3 IOLs in your eye. Just tell what is essential. Now, difficult surgical procedures, complications are expected. There could be a pseudo-exfoliation, a non-dilating pupil. Sometimes you have a bleed which is expected in a VR procedure. You could have tough membranes. These are all expected problems, but explain beforehand if necessary with photographs or drawings or anecdotes, and never scare the patient that your surgery is going to fail, so we are not going to operate you. If you are not going to operate, it's fine, but if you are going to operate, never scare the patient. You say this is a difficult procedure, but we'll do our best to see that whatever is possible can be regained. Patient should have an option of seeking a second opinion. You just don't push the patient into surgery. You advise surgery to the patient, and patient should have an option of taking another opinion. Sometimes the surgeon himself or herself can ask for a second opinion if you find that it's going to be tough. Unexpected complications you can have in uncomplicated cases. You could have a nucleus or an IOL drop, an expulsive hemorrhage. Here again, the surgeon has to explain the nature of the complication on the same day or the next day. Don't keep it for 1 month. If you had a complication today, either tell immediately after surgery or tell the patient, there are some problems, I'll tell you in detail tomorrow morning, not beyond that, and suggest remedial measures, what all can be done. This patient had this complication. There was a nucleus drop, which I am a cataract surgeon. I didn't have a vitreoretinal support in this hospital, so I'll send you to this particular person and they'll do it for you. And I'll call the doctor, get the appointment and send you. And help the patient with the right advice, and never tell the patient that it was my fault. It's never your fault. You did your best and you landed up with a complication. So it's not your fault any day. Post-operative complications, sometimes despite best efforts, you can have an endophthalmitis or an inflammation. You can have a shallow AC. You can have the IOL missing from the eye the next day. Sometimes you might have an unexpected hyphema. Explain the complication and rectify it immediately. Don't keep it for so many days. Yeah, IOL is in the eye, so don't worry. At least that first referral and handing over to the VR colleague should be done immediately, and let the VR colleague take care of that. So yourself or your colleague should explain the complication and rectify it as early as possible. If the complication is allowed to remain in the eye for a few days, the talk goes around in the town that I had a complication with this particular doctor. Can I have my slide again? Time is up. Okay. We had this complication, and so we'll manage it. And endophthalmitis or inflammation, never go into a denial mode. Always err on the side of endophthalmitis. Seek VR opinion if it's available in your center. If not, be in touch with a VR surgeon and refer when it worsens. Ask your colleague to assess the patient independently. And in cluster endophthalmitis, only the designated personnel should talk to the patients or relatives or the media, not anyone else. If you have a cluster of 5 or 6 endophthalmitis in your institution, every Tom, Dick and Harry should not go and talk to the patients or the bystanders. It should be designated to one person to talk to the patient, to the bystander, and if the media comes, also to the media. And have frequent in-house meetings, formulate opinions both in managing the patient and in communicating. Sometimes patients' expectations go beyond reality. There is a recurrence of macular edema after multiple injections. Visual recovery after a tough VR procedure or filtration surgery is not good. Here again, always talk science and give realistic expectations. You can say only this much percentage of patients have this, but always use anecdotes also. One of my favorite anecdotes in managing diabetic macular edema, sometimes patients ask you, doctor, in spite of 5 injections, I still have this macular edema. Idu povule. And I keep telling the patient, it's just like hunger. Every time you eat, your hunger goes away, but again it comes back. So it has to be managed lifelong. So use anecdotes. Managing complications of a colleague, be very professional. There should not be any loose talk. Don't defend your colleague too much and give an impression that you are trying to protect your colleague, but always talk science, manage scientifically. Same thing when you have a patient walking in with complication of someone else. Don't blame or don't defend too much and manage scientifically. And the take-home messages about these communication: be well composed, take help wherever needed, refer appropriately, be compassionate to the patient, talk science and manage scientifically, and convey the message that the surgeon and the patient are not in opposite teams, but both are fighting together against this disease, and we are together. Thank you very much.
Thanks a lot, sir.